Thank you for that kind introduction. And it's an honor to be here in an institution that has no dearth of legacy and honor. So it's my pleasure. And thank you for the invitation. Today I'm covering the topic of myocardial recovery from heart failure as the next frontier. And these are my disclosures. Not just one relevant is a cardiac therapeutics grant that supported some of the basic science work that you will see. Of course, many of you here are clinicians, and I'm not going to bore you to death with cells and mice yet. So let's start with setting the stage of why do we care about myocardial recovery? I'm sure when you treat patients with heart failure, you're sitting there desperate, looking at a 20-year-old who has DCM with an EF of 20%. And if they ask you, Doc, will my heart recover? None of us have the confidence of saying it can or it will. We do our best in assessing the etiology. We do our best in blocking the pathways. We do our best in avoiding the progression with the GDMT. And there's a lot of prayer and hope. And the question to ask ourselves is year 2025 a year where we can rely on prayers for our patients? Or is there enough that we have to do to identify mechanisms which are much more specific to what myocardial recovery means? So I think that's the stage I want to set, why this is a passion of mine, because day in and day out, I stand there and hope and expect my patients to do better with what I'm able to do. Then the question comes, what is myocardial recovery from heart failure? We all know the term myocardial reverse remodeling, which has been designed and defined fundamentally on histological parameters. So the tissue level improvement and loss of fibrosis, myocyte hypertrophy getting better. And then, of course, the ejection fraction improvement, which we stress quite a bit on, we'll talk a little about, but that's myocardial reverse remodeling. In my mind, myocardial recovery needs to be much more holistic. Of course, physiological improvement, which is to the fundamental level of even cellular improvement and genetic improvement of not just the myocytes, but the entire milieu of the heart. And if you think about it, that to me is a complete recovery and sustained recovery. And these are terms that I'm throwing out to purposefully because you'll hear the terms of remission and recovery. I'm not talking much about regeneration. You had a beautiful talk last grand rounds, and I'm not an expert in regeneration, but in the relevance of myocardial recovery, you have to understand that the regenerative capacity of the heart is limited. So hence, there's not much of regeneration I will talk about, and there's a role for regenerative therapies beyond what I'm mentioning today. So we all know this paradigm of EF focus. All patients want to know their ejection fraction, if possible, every 3 months. Right? We ultrasound the hell out of the heart by looking at it. And we know we've described an EF recovery, and the reverse remodeling goes through either complete recovery or partial recovery or no functional recovery. And this is what I mean by our current surrogate marker of EF improvement is also still not very predictable. How are you promoting recovery? If you look, this is Doug Mann has done a lot of work in this area of reverse LV remodeling as a reversal of pathology. In my mind, practically, you're removing the causatory factors, which is reperfusion, removing toxic insults, making sure your hemodynamics are optimized. I have a star at inflammation on both these areas because I think we're getting better at recognizing causatory inflammation as myocarditis, not just acute, but chronic myocarditis. But when you look at perpetuating factors, we have done a good job in neurohormonal activation blockade with medications. Perpetuatory inflammation is still not entirely established and discovered. And of course, hemodynamic unloading is relevant. So we do pharmacological promotion of recovery. There's a lot of work on unloading-based recovery that we'll talk a little about from VADS. And then what I'll try to impose on you is, I do think there is a natural ability of recovery, which is a genetic advantage in certain individuals. So if you look at the clinical relevance, this was a Penn study that essentially did a retrospective analysis of patients with echoes. Majority, of course, in this cohort had a low EF. But I want to point out the fact that even patients who had an improved ejection fraction, 59% of those, if you go back and look at their EFs, it was low EF. It brings up the question of when you see the patient in the clinic, you label them with HFpEF. What was the rejection fraction in the past? Was there a stage B drop in this EF? We don't know. And I want to bring this up because in clinical GDMT therapy, we're seeing the fields merge together between HFpEF and HFrEF, right? There are therapies that crisscross. So there's probably more commonality between these HFpEFs and HFrEFs, while there is distinctive conceptual framework, and hence recovery of the myocardium probably needs to be imagined beyond just ejection fraction. But for today, this is a decent and robust clinical parameter that we can focus on. And if you look at outcomes in this group of patients, those that have reduced ejection fraction have probably the worst outcomes. People with preserved ejection fraction do get better, but not entirely better. Similar to hospitalizations, patients who are recovered, which is a green line, they get better than the reduced ejection fraction, but their hospitalization rate is about the same as the HFpEF. So they're not completely normalized. And that comes down to the fact of, do we think even if the EF is normalized, that the ultrastructural myocardial normalization is concordant or not? And there are clinical predictors which we can sit there and embrace, but I don't find this very useful in the context of clinical decision making. It's non-ischemic etiology recovers better. Women tend to have a better recovery potential in all these studies. Some of the pathogenic gene variants that are not involving the structural cytoskeleton proteins seem to have a better rate of recovery. And of course, the LG markers and the lower biomarkers make inherent sense that if they're lesser, you have a better idea of recovery. So the focus of myocardial recovery, we have to accept, has been skewed to low ejection fraction. Most of today's talk, I will not be addressing the HFpEF pathophysiology because that's a whole nother kind of animal of pathobiology that's being described into phenotyping. But I want to embrace the fact, based on what I mentioned, that pathobiologically there is a commonality to heart failure, while there is a distinction between these HFpEFs and HFrEFs. But for what it's worth, a panel of experts, most of you in heart failure recognize all these names, but a 5-people panel put in an expert consensus document to the best of their ability. And effectively, a working definition of heart failure recovered EF was proposed as EF less than 40%, greater than or equal to 10% improvement, and your EF getting to above 40%. So take it with a grain of salt or not, but this could be a working definition for clinical assessment of heart failure with recovered ejection fraction. As I mentioned, we end up using the 4-pillar concept of GDMT, and this bar graph on your left suggests that we are still not doing as good as we should be doing in GDMT optimization. Whether your EF recovers or not, the GDMT optimization will have mortality benefit, and we should not minimize this. Of course, when you look at EF improvement as a surrogate marker of recovery, the medications seem to do a decent job to at least consistently have a third of the patients improve their ejection fraction. In some studies, it was almost up to, if you have quadruple therapy, you're improving the ejection fraction almost up to 70%, which I think is strong. Of course, the data limitation here is not all of the, actually none of the large randomized clinical trials will have consistent EF measurements on all the patients because it's expensive. And also, it doesn't matter if your EF improves or not if your mortality is better, because FDA approves it based on the mortality. So some of the data that we get will be limited. A lot of this stems from sub-studies and then retrospective analysis. But it begs the question of what is happening to the other two-thirds of the individuals in a lot of these studies, and why aren't they recovering? And we'll address that in a little bit, but these are residual gaps in the field. And then comes the whole field of chronic unloading with LVADs. And it will be a major mistake if I don't talk about the restage study in a topic of recovery. And for those of you who might not know, restage study was a seminal study that took patients with LVADs who met certain basic criteria of LV remodeling and non-ischemic cardiomyopathies. And if you put them through a concerted GDMT optimization, 15 out of 40 patients you were able to explant and keep them explanted. So that is a high percentage of individuals, even though a small study, bringing up the idea that if you unload the heart and rest it and put them on neuromodulation, even though they were labeled as end stage, can you effectively recover the hearts? Of course, this whole field of LVAD recovery has been led by Stavros, which many of you know from Utah, and again, their group and a lot of other groups have done a phenomenal job. And this review, I would recommend if people are interested in LVAD recovery, written by Manpreet Kanwar, talks about what is needed. There's a lot of focused optimization that is needed on echo optimization, using right heart cath, GDMT optimization for you to give the best ability for the LV to recover. And then you do an assessment of ability to explant, and then you explant the VADs. And of course, there's a question mark for surgical technique on do you take it out and put a coating device, or do you leave it in? But with all these question marks, the push has been, can we recover hearts with the mechanical unloading, even if they've been labeled as end stage before? And this international effort, which your institution and our institution is a part of, is the VADVIN International Registry, which has accumulated more than 500 patients who have been explanted. So that's a good number of patients whose LVADs have come out, and more data is coming out, and a lot of abstracts have been presented. I think the full papers have not been published yet, if I'm not wrong. So this will give us an insight on what are the clinical profiles. But if you are able to put an LVAD and recover the heart, that opens up this whole paradigm of, are we taking a chance? Is it worth taking a chance of recovery and not transplanting? So this whole equation of VAD-based recovery is opening up the debate on how much can we enhance recovery in these individuals. Mind it, the last literature of the current INOMAX data set shows only 1 to 5% of the patients successfully explanted. So we're not there yet. And why aren't we there is a question that we need to ask ourselves. One thing that we noticed, and this is data that was presented at UCARS, based on one of our data scientists, we have built a data infrastructure which pulls out all the data from Epic in a very organized way using the Clarity data set along with natural language processing. And what I want to point out here is when we data mined 85 HeartMate 3 patients in the past year and a half, it turns out close to 5% of the patients met the criteria of restage, even though we did not try to recover, but we never explanted because we're not looking for it. So what I call that is purposeful recovery effort versus passive recovery efforts. Today, we are programmed to put in the VAD, and we are passively expecting it to recover, while it takes a lot of effort in that algorithm that Kanwar put forth, that you are purposefully trying to recover the heart. And then if you notice, when we pulled out our GDMT dose, max doses, tolerance sometimes is an issue, but it's a very small number of patients who have maximized the GDMT. So there is missed opportunity, and this is data that has been shown nationally in the INOMAX on partial recovery, which means about 30 to 40% of the patients, their EF improves after an LVAD, but we're not explanting them. We're not pushing the realm of trying to explant. And that's something to remember if you're taking care of VAD patients and you're running a VAD program. A purposeful recovery effort is extremely relevant. And then comes the world of recovery from cardiogenic shock, which before I started looking into this concept of recovering from cardiogenic shock sounds so lethal. We always talk about in-hospital mortality, but you're not thinking about people who are recovering and going home. But the current outcomes that have been perpetuated by the shock working group are you either die after shock, cardiogenic shock, you get a heart replacement therapy, or you have what's called as native heart survival. And what I break it down is if you have myocardial recovery and organ recovery, you're probably going to go home, and that's true recovery. If you have only organ recovery and no myocardial recovery, you will recover enough that you get a heart or a VAD, otherwise you won't survive. But if you think about the native heart survival segment, which is people going home with their own heart, that in our sense is recovery after the extremes of cardiogenic shock. And this data is from all the studies of shock working group, which includes a mix of patient population, so you have to make sure you counter for it. Impella CP population is very different than patients who are getting Impella 5.0. And the native heart survival rate is ranging from 17% in Impella 5.5, because that's a biased cohort, right? We're trying to transplant them, so the number of patients who will go home will be lesser. But a good amount of 40% of the patients are going home after getting a balloon pump. Now, what are they recovered truly, or do they need more help in recovering? And what are the GDMT you can use in somebody who's in a shock state? I think these are the areas that are currently being investigated and pushed. And another fact we have to acknowledge on are we pushing the realm of purposeful recovery for shock? Because as transplant doctors, it's very easy for us to do a transplant and VAD, and for these two reasons, right? The systems are incentivized for VADs and transplants, and then we're afraid that while we're trying to recover, are we going to lose these patients because the science of recovery is not there. But we need to consciously keep in mind if we are identifying the right patients who have the potential of recovery. And again, this field needs a lot of investment and evolution for us to balance out the risk of waiting long enough with temporary MCS versus trying to get them to a VAD or transplant, because it's a subtle window. But a lot of debatable, insightful area for us to go forward with. So a few clinical pearls before we get into the fun stuff of mice and cells. So remember, 10 to 34%, depending on which study, undergo heart failure recovery with the current therapies. Irrespective of the recovery potential, you want people to be on max GDMT. Etiology makes a difference, and I would urge to invest all your effort in discerning the causes. Genetic testings are becoming more accessible. Using FTG PET and trying to do biopsies, we're doing a lot of EP-guided biopsies, and these techniques will pick up to 10% of the patients with active inflammation that will change their course of recovery. Beta blockade seems to show better remodeling than AC and ARB. ARNI seems to have the highest potential. And in real-world data, whether you have HFrEF or heart failure with recovered EF, both groups, when you compare, are on the same amount of GDMT, which opens the question, why did some people respond better versus not? And then the heart failure with recovered ejection fraction patients on the long term seem to drop their EF, and which is again opens up the unknown of what is the background remission that we need to factor in beyond what we do with GDMT. And withdrawal of GDMT is not recommended even though your EF gets improved. I think TREAD-HF trial proved that to us. And promoting recovery after LVAD needs a purposeful effort. Myocardial recovery after cardiogenic shock is possible in selective cases, and we have to force ourselves to do that. So with that discussion of the landscape that is clinical relevant, I think it is important for us because we raised a lot of question marks. There's a lot of unknown. So where do we go from here? And it probably is important to understand a little bit about the biology of myocardial recovery. We have spent a lot of effort as a group of scientific investigators and clinicians on understanding the concept of heart failure pathobiology, right? So you get an insult, you might have a genetic causation or a genetic predisposition. There could be causatory inflammation, and then you get deranged function. So while there's a lot of focus on avoiding these to prevent the onset of heart failure, a lot of what we do is focused on tempering down the heart failure syndrome, which for the most part is centered around the neurohormonal activation. Inflammation and other hemodynamic factors as a remodeling concept have evolved. Cardiomems have shown that if you decompress the heart, probably you'll remodel better. And fundamentally, even though this pictorial represents an MI model, we have understood LV remodeling, and there is a concept of replacement scar. And you saw in the last grand rounds where you saw beautifully how the heart can regenerate with some of the innovative therapies you guys have here. But what is not conceptually focused on much is the interstitial scar, which involves the entire myocardium beyond the infarcted zone or in non-ischemic cardiomyopathy. So it's easy to maybe say, all right, if this is what happens in remodeling, you just drag everything back to normalcy. Maybe that's what recovery is. It's just a reversal of pathology. And is that a simplistic way for us to understand or not? The LVAD world, like what Stavros has established, has really opened up our eyes for reverse remodeling, because I fundamentally think prior to the VAD world, we did not imagine that scar can be easily reversed. A scar was presumed to be something permanent. But these experiments and these studies have really showed us and opened up the world for us to explore the biology of reverse remodeling. There's a plethora of studies. The limitations, though, was very well acknowledged by Ken Margulies in this paper, because the human samples and the human cohort that give you an insight have a limitation as an experimental model. Only 5% of the dysregulated genes turn to normalize during LVAD support. And maybe that's because we're looking at end-stage samples, and maybe these patients are not true recovery because you're transplanting them. So you're comparing a cohort which is not fundamentally true recovery. And then there's a lot of biological variations and many confounders that come with this experimental design that we've used to understand myocardial recovery. So let's step a little bit back and try to understand some fundamental biological principles why this needs to be revisited. The most prevalent imagination, if I tell any of you in the room and most of the fellows, if I say the heart, the first thing that comes to your picture is this diagram of these beautiful myocytes, right? But what is missed, and the paper on the right is a recent publication that we were able to do with my collaborator in Northwestern, looking at using a nanopore technology for single cells, without going too much into all those lines and squigglies, some of which I myself don't understand. I want to point out to you this particular box, which highlights groups of cells that are identified by single cell technology. There's a lot of cardiomyocytes, no doubt. They're the workhorse of the heart. But look at all these cells, including a big band of endothelial cells, and each of the dot is a cell over there. So there are a lot of non-cardiomyocytes, which in my mind have been the forgotten cells of the heart that have not been given enough importance. To thicken the plot further, it turns out there are 5 kinds of cardiomyocytes, 4 subclusters of endothelial cells, 3 subclusters of fibroblasts. What that means is a cell that looks like a myocyte might not be the same functionality as the other subtypes. So this has opened up the complexity of the infrastructure of the heart to be much more complex than what we imagined in the past. And another study in Nature Biology effectively took human samples and did single cell analysis and compared. What you see over here is a comparison of, these are cardiomyocytes, endothelial cells, fibroblasts, and this kind of graph gives you the gene expression and the delta changes that you see between these lines compared to normal, which is red, and these 2 lines are two different pathologies. One is ischemic disease and dilated cardiomyopathy. What I want to point out is, of course, the cardiomyocyte programming changes because it gets affected, but look at the distance of the fibroblasts, which makes sense, right? Because we get a lot of fibrosis. So, and in this study, they ended up finding that a subtype of endothelial cells, actually subtype 3, seems to have a protective effect, and further validated by just two patients that they looked at LVAD, one patient who recovered and one patient who didn't recover. And they essentially saw that this patient who recovered had a huge delta change in their gene expressions of their endothelial cells and fibroblasts, making you believe that in these patients, the non-cardiomyocytes actually experience a much delta change from pathology to normal. And maybe there is a focus in these that are the master orchestrators of the workhorse, and we're missing the importance of these cells for us to be able to control or modulate the heart failure segment of it. That brings me to an area that I've focused the last decade on called the endothelial to mesenchymal transitioning, an area which has been wrought with controversy, but it's a fascinating concept for clinicians like us where we don't spend enough time imagining the cells in the human in front of us. But these endothelial cells that you see up there actually transform into fibroblasts. And when endothelial cells transform into fibroblasts, it's been an established concept in embryology, where that's how your embryo develops. It has been an established concept in cancer, because that's how the cancers metastasize. In fibrotic diseases, there's been a lot of work in other diseases until in heart failure. This was a seminal paper by Zeisberg in 2007, where they have a way to tag the endothelial cells and give it a birthmark. So imagine that if an endothelial cell is born endothelial cells, it gets a birthmark which never goes away. And then when you take these mice and put them into heart failure, they all transform into mesenchymal cells and fibroblasts. But if you have the birthmark, it means that they were born endothelial cells, they've transformed into fibroblasts. So using some of these fundamental techniques of tagging these cells, they showed that about 30% of fibroblasts in a heart failure model came from the resident endothelial cells. Right? Of course, there's other 70% from the bone marrow and various other aspects of it. And of course, since then to now, multiple papers have shown the role of endothelial to mesenchymal transitioning in various organs, in ideas of calcification and fibrosis in cardiovascular medicine, having a traction that this might be an area that is important for pathology. And why is that important? Because this review in 2016 had a nice diagram with too many question marks than no question marks, because the source of the myofibroblasts, which are the troublemakers in the heart, has always been controversial. And there are resident fibroblasts, which we believe we know. There are perivascular cells, but the endothelial cells, whether they contribute to the load of the troublemaking cells, has always been question mark, and that's the area that we're focusing on. And with the idea that if you go upstream to the source of the troublemakers, can you temper down the pathobiology of stiffening the heart, which is fibrosis? So with that in mind, we investigated a mouse model of heart failure recovery to overcome the limitations that I mentioned, that in human samples that we have, we are wrought with non-controlled setting. And this was an interesting story because our fellow Sophia at that time serendipitously discovered. So we have a mouse model of heart failure, which I'll walk you through here, where we do L-NAME and sodium chloride in the water and do angiotensin II infusion. And then by week 5, they all get fibrosis and heart failure with a reduced ejection fraction. And it turns out we had a few mice which just survived and we left them alone. And then at week 19, we sacked them and all the fibrosis was gone. So that's kind of how we stumbled upon this idea that everybody has spent enormous effort in defining the pathobiology of heart failure. We need to figure out how this concept of natural recovery happens. So with that in mind, we devised this model, and we picked 19 weeks because that was our serendipity discovery. But what you notice in this model is that By week 5, you notice that the ejection fraction drops, but by week 19, it's completely normalized, natural recovery. Fibrosis peaks at week 5, which we've seen before, but it plummets down by week 9 and then kind of stays back. And you see all this blue fibrosis is gone. So we're very excited to, of course, see this. And using this model, we did some gene expression profiling, full gene expression profiling, and these are heat maps. I want to point out that this is control, this is heart failure, this is recovery. So you notice how recovery completely changes from heart failure, looks very similar to control, but not entirely the same as control. And without going into the complexity of all these diagrams, what I want to point out is there are a set of genes which do not normalize in recovery. And more importantly, and maybe these are the answers for remission and clues for remission that we can talk about. But what we then did is we took this gene expression profiling and said, let's track genes that go up for heart failure and in natural recovery all come down and not stay persistent. Similarly, all those that go down and come back up. And when we data mined these genes, many of these pathways, of course, this was a biased approach of us looking for these, point towards mechanisms which have been established in endothelial to mesenchymal transitioning. So we use this to hypothesize, and I use the word hypothesize because this has not been validated by blocking experiments and other things, that endothelial to mesenchymal transitioning as an active process does contribute in heart failure, and there might be a reversal mechanism that this is contributing. Of course, other pathways that showed up was metabolism, DNA repair, RNA metabolism, mitochondria, myocyte interactions make sense relevantly. But the fact that the non-myocytes have a big role and it's reversing made a point that maybe the non-cardiomyocytes are something that we have not paid attention to as much. And we went further and used paired myocardial samples of VADs pre and post and validated that in pre and post, selected genes of EMT in this matched paired samples actually also follow a similar pattern that we noticed in the mouse model. And in the human tissue samples, we identified what's called as dual staining cells, which stain for both VE cathedrin and FSP1. VE cathedrin highlights endothelial cells, FSP1 highlights fibroblasts, and if you find both on a cell, it means that it could be a transitioning cell. There are controversies on how specific these are, but this is a validated technique that people accept that you have documented transitioning cells, even in end-stage heart failure in these patients. And then the next step that our informatics guys were able to do was do some gene expression changes curves to suggest that the directionality of changes in this heart failure to recovery in mice was very similar to the directionality in the human samples of the VAD patients whose pre and post samples, giving us a ability to say that maybe the mouse model is quite reflective of the human directionality of unloading and recovery, and if this model can be further used to study the concepts of myocardial recovery. And of course, we saw the fibrosis changes, and these things, I think, are established in the human samples. So we concluded saying that the mouse model of passive recovery, and I call it passive because it's natural recovery, it shows both phenotypic and genotypic reversal of the pathology, and the changes were directionally similar to the VAD patients pre and post. More importantly, the genetic recovery at a genomic level was not a passive normalization of the pathology. It was an active process. And the similar concept was put forth by Stavros's group recently in the single cell analysis of the VAD sample, saying we can't imagine that recovery is just a reversal of the pathology. There is an active healing process that happens, opening the opportunity of further interfering and enhancing that aspect of it. And our bias, of course, is a mechanism of EMT or endo-MT that plays a transition in the role of heart failure and myocardial recovery. And this is not published in the paper, but we also showed that in the mouse model, this dual staining cells that you see that point out the vasculature is populated by these dual staining cells transitioning, seem to peak at week 3, making sense that these endothelial cells are peaking to double staining cells and they become fibroblasts. So by week 5, they're already fibroblasts, so they're not going to dual stain. The endothelial marker is gone. And then interestingly, the dual staining cells peak back at week 7, opening up this hypothesis that maybe there is a reversal of this phenomena where your mesenchymal cells are becoming back into endothelial cells so that your fibrotic milieu is getting better. So this fascinating concept kind of opens this idea of cell transitions going back and forth to replenish or deplete the workforce of fibrosis, which is the fibroblasts. So hopefully this is a target that we are continuing to pursue. And then I'll come back to that. We also ended up doing a genetic analysis of the cells of the genes that stay persistently abnormal. And this was published in JHLT Open. When we take the gene changes that in the recovery are persistently abnormal to heart failure, it turns out there's a list of genes that are elevated, persistently elevated, but transferrin gene was the only gene that was downregulated persistently, identifying that this iron metabolism, which has been a controversy in heart failure forever, at a cellular level might be contributing it, not as much as anemia or oxygen carrying capacity. So this, of course, needs further study, but all these areas of extracellular region, the transferrin complex, and various metabolic pathways that we found could be the answer for what I call as the remission state, because you have recovered, but you have not genetically normalized. And if you find these targets, can you modulate them to make a sustained recovery in these individuals, which will be the quest of it. So that's the version of me from ChatGPT. It's pretty good. But for every complex problem, there is an answer that is clear, simple, and wrong. And the reason I say this is, I think we try to simplify things for practicality, which is relevant. But you have to ask yourself that, is it silly for us to try to simplify the biology of a complex organism and find solutions? So I think I'm a strong believer that you want to embrace the fact that this field is complex. While I am focusing on myofibroblasts and endothelial cells, it will be stupid to imagine that the rest of the heart is going to just sit there and do nothing. So the investment in recovery comes from, while we're using tools of mouse models, human pre-post samples, biological data sets from stage C patients who recover, we have to acknowledge there is a whole plethora of cell talk, matrix, proteomics, and then immune mechanisms that contribute to recovery. And it has to be a holistic approach so that you come up with a comprehensive strategy in this particular investment. So then where does this future of this field hold? And some of the exciting things that I'll briefly point out for clinical applications is using acute MCS to support and promote recovery. And I'm sure, I think some of you have seen the counter pulse, the new pulse device, which was a surgically placed balloon pump with which people could go home. And then this is data from our center showing the validity of axillary balloon pumps, which you guys also do, to keep people stable in the hospital to get to a vado transplant. But can you use these support systems to then promote recovery? And the BTR study with Impella is an area that's being pushed with devising a pump, Impella pump that you can go home with. But how do you then promote recovery? I think we've learned from the VAD world that if you just unload the heart and rest it, you can't just expect it to recover, right? You have to then do pharmacological promotion is one strategy. And pharmacological promotion is not an easy task if you think about it, especially in people who are in Impella, you're trying to beta blockade them, give them ARNI. And that opens up this idea of, can you enhance the natural ability and use a strategy which is in a different era of modulating the genes instead of blocking some pathways. And that's one area that I'll talk a little about. Similarly, the door to unload trial has opened up this realm of recovery by unloading and modulating the hemodynamic concepts of reprogramming the heart. And the idea that opens up in both of these BTRs, unload and balloon pump, is what can you do further to enhance recovery mechanisms? And medicines might be an easy solution to start with, but is that a feasible option in these sick patients? Hence the idea of the current era of genetic modulation. And we've seen the plethora of advancements in gene modulation. And when you talk about genetic modulation, I break it down into, you need to know what target you're trying to modulate. You need to know what vehicle you want to use to deliver this particular goal. And then what is the level of intervention? DNA alteration is the CRISPR-Cas9 viral vector strategy. We've chosen RNA vector strategy, and I'll show you what that is. And of course, you can do protein modulation also. So circa-2A trials in heart failure, in cardiovascular medicine, heart failure has led this field of injecting viral-based circa-2A promotion, and currently the trials are ongoing. This was an older trial which saw some benefit. Company went under, they came back with the Sardacor and Music HFrEF trial, where they're promoting the calcium handling. Will promoting calcium handling in the heart be enough? I don't know. I'm a little skeptic about it, but we'll see. But this has really led the field for us for genetic modulation. And the other concept is, can we get rid of these medications? Can you do genetic modulation and not worry about taking 2 million pills, right? So facilitating MCS-guided recovery, and then more targeted recovery targets so you don't have to take neurohormonal blockade are two hypothetical scenarios to think about. So quickly, why RNA therapies? We have RNA avoids the long-term irreversible manipulation of the DNA. It also gives you the recurrent therapy so you can control it more commercialization-wise. Cost income is one aspect. The other aspect is you can stop it if you don't need it. The barriers are that RNA is very volatile, and you have to deliver it to the target, and you need the cells to actually take it up, take the RNA, and then manufacture the protein. So there are some barriers that you have to come up with. And as I said, the viral vectors have been well established, but they come with a lot of limitations, which I'm not going to get into, and hence we chose a nanoparticle delivery systems for the RNA. So the first question is, what target? Based on our mouse model, we found that there is a gene which will be called as target gene for the rest of the talk because I can't disclose the name of it. That we picked a gene that had a biology behind it, but also lowered down during heart failure and went back up. And with that in mind, we ended up devising a RNA genetic modulation, and I'll walk you through this. This is a in vitro model that we created to study endothelial to mesenchymal transitioning by stimulating the endothelial cells. HUVECs have been represented. We have replicated this with coronary microvascular cells. But what you see up here is HUVECs, they're cultured HUVECs with L-name and angiotensin 2, which is the insult that we use in our mice, essentially shows you that the endothelial cells are transforming into fibroblasts. These have not been stained for fibroblasts here, but this essentially shows that when we cultured this with our target gene mRNA, the mRNA was taken up by the cells and expressed. So that was the first victory that we're able to actually transfect into the cells effectively, and then it's taking it up. And then the therapeutic applications is, these are HUVEC cells that you see CD31 is a marker of endothelial cells. When you put them with L-name angiotensin 2, they don't express as much as CD31s, but they start expressing vimentin, which is a mesenchymal marker. And mind you, we started with endothelial cells, so there's no fibroblast it's not in the body that's coming. So these endothelial cells transform into fibroblasts with vimentin production. When we culture them with our RNA, you notice that all these cells have been preserved. They don't express as much vimentin, and their cell survival maintains as endothelial cells. And this is just a replication with a different marker, so we replicated it. So we were very excited to show that the target mRNA is taken up by the endothelial cells, translated into the intended protein, and impacted as an anti-endo-empty mechanism. A lot of this work was done by my postdoc, Muthu, who's in the audience. I think I dragged him over here to sit through some clinical lectures too. And then we went further to see, can you reverse the endo-empty? Because it depends on when you see these patients, right? Sometimes you see people at the later end of their stage of heart failure. And in this model, what we do is we convert the cells into mesenchymal cells, and then after that, we put them, continue the injury, and then start the treatment that we want. And at day 8, you notice that actually cells are able to come back into endothelial cells, proving to us that the cells that transitioned here were able to come back into endothelial morphology, suggesting that reversal concept of the endothelial cells and having that plasticity to come back to endothelial cells. So once we saw that the target makes sense, we then build the mRNA sequencing to an extent that is able to be delivered, and then manufactured a nanoparticle using basic lipid nanoparticles, load them into it, and then we went forward with testing it in the mice. And with sub-Q injection in the mice, it turns out when you give our gene therapy, the fibrosis is all abrogated, and then you see that it's preserved, very similar to protein infusion. And this is currently a patent that is brewing, with a hope that this RNA-based lipid nanoparticle delivery systems can work as an anti-fibrotic mechanism beyond whatever else that can happen. And to validate some of these concepts, we ended up taking myocardial samples from patients who had a balloon pump and an Impella and got transplanted or got a VAD, with the hypothesis that transaortic LV unloading is a better way of resting the heart and unloading compared to a counterpulsation device. And with this, with RNA bulk sequencing, we found a lot of genes that are better or are changed, modulated in the LVAD patients, but we were happy to see that when you compare the VAD, if more effective unloading compared to heart failure, our target gene was actually upregulated in this cohort, giving us a proof of concept that this might be playing in human pathobiology of unloading and antifibrotic state. We're further studying, as I mentioned, I think it is foolish not to go beyond what we find just in the endothelial cells. And using our platforms in the mouse model, we're further studying a synthetic cannabidiol, which is known to have beneficial anti-inflammatory property. This is a Cardiol Therapeutics company that we partnered with, and there's an international trial that's been done in myocarditis, and they're having an international human trial in pericarditis. But what we noticed in our mouse model is it's anti-fibrotic. So when we give this CBD, there's no fibrosis that comes up. We've also showed that it promotes the recovery, because this is natural recovery at week 7. When we give CBD, the fibrosis comes down further, showing us that the CBD can enhance the recovery in the natural mechanisms. So the hope and goal is you add on the fibrosis to the immune system with what I call as the understudied immunofibrotic axis. We have neurohormonal axis, we have hemodynamic axis. The immunofibrotic axis has been understudied. The interplay of healing with fibrosis, the interplay of the immune system modulating the fibrosis of the organ as a response to injury, is an opportunity that we're trying to study further, and we've done a large set of experiments that are brewing with RNA expression, where hopefully we'll find some other clues than what we're doing right now in human trials of blasting with IL-6. I think the Hermes trial is an anti-IL-6 in heart failure that's being studied right now. That sounds reasonable, but I think that is so archaic in the concept of how complex the immune system could be. So hopefully we'll have more discovery for that. And finally, tissue regeneration for the last myocardium is still needed. And I put this picture from last grand rounds that you guys have, because I mean, that was one of the fascinating areas that you've seen. He showed a slide, Dr. Purdon showed the slide where the myocardium regenerates, right? So I don't think regeneration can be substituted, because all I showed you was the interstitial fibrotic areas but if you lose an amount of myocardium, you still will need to regenerate. And then this is just pictures from the recellularization concepts that Davis Taylor showed. So these are areas which are fascinating, which will rebuild the myocardium. And then you have to use other strategies to promote the natural recovery is the hope. So I'd like to conclude that myocardial recovery can happen naturally, which we do on a day-to-day basis, but it's not a predictable pattern. And there's a lot that needs to be done in understanding the biology of this recovery strategies and the recovery that happens in the current world. And then hopefully genetic manipulation with whatever strategies you use will be an option beyond just neurohormonal blockade. And regenerating the lost myocardium is always a necessary stuff. And I always put this up in slides for heart failure because I think while we get lost in the science, a lot of our patients are living the suffering and enduring the disease, and we always need to acknowledge our patients for that. And then I hope my dream will come true that one day we can identify people who can recover, promote it quickly, and then enhance their natural ability to make them an advantageous situation to recover their heart for better survival. And I want to point out the edition from Tibeki Journal recently that I had the pleasure of being a co-editor with Jim Young. And there's a lot of nice articles that good people across the world have written. So if you're interested in myocardial recovery, you can go through some of these reviews. With that, I'll stop, and I'm open to any questions. Thank you.